Hello, good evening, everyone. Welcome to ICPA Clinical Series. The theme of ICPA Clinical Series is one clinical challenge in each episode. We try to provide as much clinically relevant content as possible. And we had our last episode, seventh episode in the month of December. And then because of Omicron wave, we had kept it it had taken the back foot. And now we are restarting it. And today we have the eighth episode. And we have again chosen a very relevant topic for clinical practice, especially for implant practice. And it is top three challenges beginners face in full mouth implant rehabilitation. A very interesting topic. A lot of beginners look for solutions in this domain. And for to address this topic, we have none other than Dr. Amol Thorat, my very good friend and batchmate from GDC. Let me read out his introduction. Dr. Amol Thorat completed his BDS in 1998 and MDS in prosthodontics in 2003 from Government Dental College and Hospital, Mumbai. A full-time implant practitioner in Pune, an implant consultant to many clinics in other cities, and known for his outstanding surgical and prosthetic skills. Dr. Thorat completed his advanced training in implants from Sonthofen, Germany in 2006. He completed his clinical mastership in oral implantology from State University of New York, USA in 2015. He is a diplomate at the International Congress of Oral Implantologists and also Indian Society of Oral Implantology. Apart from being a faculty at multiple reputed academies across India, Dr. Thorat runs his own academy, Thorat Implant Institute in Pune. So we have a great clinician, a great speaker with a great topic. So Amol, the stage is all yours.
Thank you, Rajiv, for your kind words. I hope I am audible.
Yes,
Yes, thank you very much. Uh,
you can share your screen.
yes, great. So, thanks for inviting me to the ICPA clinical series. Today, I'll be talking about full mouth implant rehabilitation, common challenges which uh, the beginners face. This is what Rajiv said. But to be frank, full mouth implant rehab is not meant for the beginners in the field of implantology. Yeah, so beginners in full mouth rehab is what I would like to say. Uh, I would not be elaborating much about the theoretical aspect of it, but more about the clinical part, how we manage such scenarios. Friends, we all know that India makes you feel like a superstar. We are unique in many ways. One of them is the game of cricket, which we worship. Another is the cuisines that we can boast of, having maximum number of cuisines. I have not seen in any part of the world having so many cuisines. And we are also unique as far as our genetics are concerned. We Indians and people in Southeast Asia, this part of Asia, we are unique in our genetic makeup, in that genetically we are having less bone as compared to our European or American counterparts, and that poses a very big challenge as far as implant practice is concerned. So coming to the characteristics of Indian patients, we have number one, deficient bone. Number two, there is lack of awareness and motivation. Number three is the habits. There are certain habits which are uh, seen only in this part of the world, like for example, betel nut chewing, tobacco chewing, gutka, and so on. And we have so many patients having these habits for decades, coming to us for full mouth implant rehabilitation or full mouth rehabilitation, and we have different challenges to face when we are treating such cases. And last but not the least is the affordability. India is a price sensitive market, we all know that, right? So we need to devise a treatment plan which will suit these patients pockets, which will not be very technique sensitive, and plus it will be, the implants will be placed in the available bone, because frankly speaking, again, the question of affordability comes. The more grafting procedures we involve, the problem is It involves more of morbidity, it involves a lot of cost, many surgical appointments, and time. So practically, what I'll be speaking is how to treat a patient with minimum number of visits with minimum costs, which is practical. I mean, not that I do not do ideal cases or I do not give ideal outcome, but that does not happen always. It happens what 20 or 30% of the time. 70 to 80% of the time, what we do is some kind of compromise for whatever reasons, right? So I'll be discussing only about three cases because we don't have too much of a time. And then we'll be talking a bit about the treatment planning, also how to plan any case for implants. I've been given say about 35 minutes, so let's start with the presentation. Why am I speaking on this topic is because of late I'm doing only full mouth implant rehabilitation. I've been into implant practice for about 17 years. I've been into consulting practice for about 20 years, with more than 100 clinics, starting from Mumbai to the remotest part of India. Done some fair good amount of full mouth implant rehabilitation in different scenarios, in different clinics with different treatment outcomes. And I'm still learning from my failures and being and learning by sharing my cases, sharing my views, and by teaching as well. Okay, so let's talk about the critical problems that we face day in and day out. Number one is managing aesthetics and function in deficient bone. So this, understand what I'm talking about. We have to manage the aesthetics. Patient wants to look good, patient wants to eat properly. At the same time, we don't have sufficient bone in the patient's mouth for whatever reasons. It may be because of lack of awareness, it may be because of habits, it may be because of infection, it may be genetic. So for whatever reasons, we are not having sufficient amount of bone. And plus the patient wants to look good because he or she is paying us in lakhs, right? And we have to restore the function, of course. Second is, I've been into consulting practice for almost 2 decades now. So what I have realized is, more number of times I visit that particular clinic, less is my profitability. Okay, so I have to complete that case in minimum number of visits. So I'll tell you how I do to reduce the number of visits. And the third critical problem is managing extreme bone loss cases. Okay, so how do you manage extreme bone loss cases? I have read some of the questions that have been asked by the audience, and they have asked, some of them have asked, which implants are better, what design is better, is basal good, is conventional good. So we'll discuss that in due course. Okay, so the first problem is the managing aesthetics and function in deficient bone. I'll give you an example. I'll explain this with an example of a case. So this is a typical full mouth implant rehab case. So how do we treat this case? We place about 5 to 6 implants. That is my favorite configuration, about 6 implants in mandible and 7 to 8 in maxilla. Normally I try to place 1 or 2 implants more in maxilla for many reasons. One of them is soft bone, another is poor angulation, and third is your maxillary arch is placed outside the mandibular arch, so the forces are not directed along the long axis of the implants, and so on. So I generally place 1 or 2 implants more in maxilla. So coming to our first case, Mrs. Mansi, she is about 52 years old. She is a gazetted officer, deputy secretary in the government of Maharashtra. And she comes to me like this. The OPG was shared to me before I saw the patient. So she was having few teeth when this OPG was taken. And by the time I saw the patient, she lost the remaining teeth in the maxillary arch. This case was done in 2017. Now the patient was having the problem of inability to eat, low self-esteem, and she, because she was a government officer, she said it becomes so awkward. I have not laughed for like many months now. Okay, so that's a social awkwardness that she was facing. Her main problem was, see, again in this case, economic constraint is not there, but the problem is she can't go without teeth even for a day. So she said, doc, I can take maybe a 2 or 3 days off, but whatever you do, don't send me without teeth. I can't go to the office without teeth. I can't stay without teeth even for a day. She was wearing a removable partial denture, an acrylic partial denture when I saw her. Okay, but even that was not fitting because the teeth were mobile. So what? How do you plan such case? Again, this was done in consultation. I stay in Pune. This case was done in Dadar, and the problem was minimum number of visits. That was the first problem. Second was I have to restore her with a temporary restoration immediately because we couldn't send her without teeth, right? So how do we plan such case? Again, if you see posterior maxilla, we have deficient bone. We don't have sufficient bone below the sinus to place straight implants and load them immediately. So in this case, the problem was I have to place the implants. I need to take out those teeth, place the implants, but probably I won't be getting good primary stability because I am doing a sinus augmentation procedure. And when we do any augmentation procedures, ideally we should not be loading our implants. Okay. So what I did in this case was this is the intraoral photograph, upper and lower occlusal views. These lower teeth, even though you are seeing these teeth, they are all grade 2, grade 3 mobile. So there is no point in saving them. Okay. So what we did here is we placed 8 implants in maxilla, and they all were submerged. We did bilateral sinus lifts. 6 implants were placed in mandible, and because mandible was having enough bone, I won't be elaborating much about that in this presentation. We placed 6 implants, loaded them immediately with final prosthesis. So that was as simple as that. As far as upper arch is concerned, we placed, you can see, 8 implants. Sinus lift was done, and then you can see 3 narrow implants in between those conventional implants. These are one piece implants, and left canine is also saved in this case. Okay, so these the thin implants are known as transitional implants. Normally we use them for giving provisional restorations. In this case, these 8 implants were submerged. I could not load them immediately, so I had no, and I could not send the patient with without teeth. As far as complete denture is concerned, as a provisional restoration, any removable denture, I'm thoroughly against it. I'm completely against any kind of removable denture over submerged implants. The reason is these removable dentures rest on underlying tissues, soft tissues. Okay, so every time the patient eats with those dentures, what happens is the soft tissues compress and the underlying implants are stressed, and we can't control those stresses. That's the basic reason. Okay, so the sole purpose of submerging those implants is lost if you are giving a removable complete or partial denture over submerged implants. So if I am submerging the implants and I have to give any kind of provisional restoration, I would use these transitional implants. They are a very, very good choice. They are one piece implants. The difference between normal one piece implants and these transitional implants is that the surface of these implants is not treated. That's the only difference. So they are basically machined screws, one piece, which go into the bone. Okay, so where do we place them? Wherever we find space. Okay, in this case, I placed my implants, the conventional implants, in strategic locations, and wherever I could find space. Basically, you need to have a at least a tripod to stabilize your provisional restoration. So you can see 3 implants are placed, one in the center, two on the either side, and we have one canine also which was retained. So I took support of this canine also. As of now, we'll decide whether to save this canine at a later date. So 3 implants plus one canine was a good support, and I gave her provisional restorations for 4 months. After that, she comes back. This is on the day of surgery and 4 months after surgery. So we did stage two, and this is how the soft tissues have healed. You can see these 3 transitional implants, 1, 2, and 3 over here, and other 8 implants which have healed nicely. You can also see the left canine which stays there. She was having some sensitivity in that canine, so we decided to go with the endodontic treatment for that canine. But because it was absolutely stable, the canine was used as an additional support in the final prosthesis. So this is the frontal view. You can see the transitional implants along with the canine. Now, during the restorative phase, what happens to these transitional implants? Now, in this case, they have served the function for 4 months, and my purpose is solved. my implants have integrated nicely. So these three transitional implants are not of much use to me. Okay, so we have two options: either we remove them or we keep them. Now in this case, what happens, these two side implants, they were slightly mobile, so I removed them. There was no question of keeping them. The implant in the center was absolutely rigid, but the problem was it was absolutely in the center, and it would have been an aesthetic disaster if I would have included that implant in the restoration. So I trimmed it to the bone level and let it rest in peace. And my 8 implants had integrated. So we went ahead with the final prosthesis. Again, I had to complete the case. I had already taken 3 or 4 visits. So we had to finish the case in minimum number of appointments. So this is how we did. Nothing great, it's cement retained restoration, but it is serving the purpose. It's been like 4.5 years since I have completed the case, and I was able to do it within 6 months. 6 months, because like in Maharashtra, what happens is one of the session is in Nagpur. So because she was working in a secretariat, in between she had to go for that winter session to Nagpur, and she was not able to see me for a few months. So it took about 6 months, but in 6 visits, I started from here and ended here, and it's been 4.5 years, and patient is thoroughly happy with whatever she has got. What I have shown you over here is clinically what we do, not the bookish pictures. Having absolutely fantastic screw retained prosthesis, I do have such cases, but here I want to address the issues of the clinicians, uh, some practical issues. Okay, to start with. Yeah, so this was my case number 1, which we finished in minimum number of visits. Now, second problem is consulting implant practice for all those consultants who visit various clinics. As I told you, number of visits, in more number of visits will directly affect the final outcome financially. Okay, so we have to complete such cases in minimum number of visits, right? So this was one of the cases where I had to travel close to 500 kilometers to treat this patient. And of course it was not the only case that I went for, but again, the thing is, we need to finish our cases in minimum number of visits. So this young lady of in her 60s, she wanted to suddenly look good. The oral hygiene was completely ignored. We can see this in the intraoral photographs. This case was done in 2013 or 14, about 8 years back. Okay, so there was no point in saving any of her teeth. We had to remove all of her teeth, right? And so we went ahead with, as I told you, my favorite configuration: 8 implants in maxilla, 6 implants in mandible. Now here you can see that the distal 2 implants in maxilla are not loaded, and the remaining 6 are loaded with provisional restorations. 6 implants in mandible, immediate loading. If you can see these implants clearly, then I would like to inform that these are the tissue level implants, not the conventional root form bone level implants. Tissue level implants is one design which is my favorite when I generally do full arch cases, or in all my posterior implants. I use a lot of tissue level implants. I know there are very few people using them, but there are distinct advantages associated with tissue level implants. One of them is, if you have seen or if you have read Thomas Linkevicius, he talks a lot about zero bone loss concepts. What he says is you always give screw retained prosthesis, because one of the major reasons of implant failure in the long run is the over retained cement in gingival sulcus. Now, in tissue level implants, we are operating at the tissue level, not at the bone level. So, chances of the cement getting lodged into the sulcus are minimum. So, that's one advantage. Second advantage is, if you know about the Zipprich movement, that is the movement occurring between the implant and abutment. You have an implant and you have an abutment which goes and fits on an implant, but every time the patient eats, there are occlusal forces which causes some movement between implant and abutment. And in bone level implants, this movement occurs at the bone level. Okay, that is the Zipprich movement. And because there is no junctional epithelium, the gingival sulcus is filled with microorganisms. the colonies of bacteria, and with this zip rich movement, these bacteria are continuously pumped in and out of the implant abutment junction, and that leads to crestal bone loss in a long run. So with this tissue level implants, whatever you are doing, everything is away from the bone, is about 2 millimeters away from the bone at the level of the tissue. So again, the chances of bone loss because of zip rich movement are minimum. So at the same time, I don't need to do a stage 2 procedure. I told you, consulting practice, I save one visit just for stage 2 surgery. So I place the implant, place the cover screw, and I don't need to do a stage 2 surgery. At a later date, I just have to take the impressions and go ahead with my prosthesis. It may be a screw retain, it may be a cement retain, but that definitely reduces 1 or 2 visits. Okay, so tissue level implants are my favorite for lower arches, non-aesthetic zone, posterior edentulous areas. I generally nowadays avoid tissue level implants for aesthetic zone, but in non-aesthetic zones, it's the implant of choice. Another advantage of tissue level implant is, if you see, the crestal part is divergent. So when you have this divergence at the crest and you are placing these implants in maxillary posterior region below the maxillary sinus, especially if you have done a sinus lift procedure, I have seen, even I have a couple of my implants have gone into the sinus at a later date. So the advantage of tissue level implants is because they are divergent cervically. There is no chance that they will be pushed or pulled into the maxillary sinus. So even if they fail, they will come out and not go into the sinus. So that saves our skin to some extent. Yeah, so these are the advantages of tissue level implants. So we started from here, and this is the final outcome, and this is how the patient looks. The case completed in 3 visits. The first visit, we placed the implants and gave the provisional restorations. We waited for about 4 to 6 months, 4 months, and then at a later stage, we took the impression and gave her metal ceramic prosthesis. There was one question I was just going through. This doctor has asked me, can we give one piece full arch prosthesis? My answer is definitely yes. Last more than uh, say 12 years I have been doing this. First, like 3 4 years of my practice, I was going as per the books. I was splitting the framework into 2 or 3 pieces, and then I did not find any added advantage of splitting it. They say mandibular flexure, but I'm not very sure about it. I've been doing one piece prosthesis for quite some time. 12 years is a long time. So from 2009 onwards, I have stopped doing 2 piece or 3 piece prosthesis. I do all 1 piece prosthesis, and it does work. Okay, I'll tell you the trick in a while during our question answer session. So this case was completed in 3 visits. We started from where we have seen, and we ended it here. Patient is happy. It's been 7 8 years since the patient is using this prosthesis. The last case which I want to show you is how to manage extreme bone loss. And uh, coincidentally, nowadays the cases that I get in my practice, whether it's my own practice or in consultation practice, is severe bone loss cases, because straightforward cases other people do, and then when there is no option, they send those cases to back to me. So most of my practice nowadays is managing this such extreme bone loss cases. Okay, so let me show you this case. This guy in his late 60s, retired bank manager. Now, he had been to many dentists in Pune and many prosthodontists, 2 3 prosthodontists also, and coincidentally, most of them referred him to me somehow, and he landed to my clinic. Now, the problem was, he has had been chewing betel nut for over 4 decades. And when he met me in 2017, he had just left that habit. Okay, so the problem was his mouth opening was very less. Now, if you have seen my earlier cases, my photography is not that bad, intraoral photography. But here you can see there is hardly any mouth opening. And this is maximum I could get from him. So there was hardly like 2 fingers opening, and his x-ray showed hardly any bone in maxillary arch. There was some bone in mandibular arch. Okay, so it was a big challenge, because mouth opening also was less. I have spoken about this case at various platforms, and there were some people asking me, doc, why have you not gone with pterygoid implant, or why have you not gone with zygomatic implants and whatever tilted implants and so on. My answer is, in limited mouth opening cases, these treatments are impossible to do. Okay, so we need to keep our mind open, we need to keep our eyes open, and we need to embrace all the treatment modalities rather than having any bias towards any one treatment modality. Okay, so I will show you how we treated this case. Lower arch, as I told you, was pretty straightforward. There was a sufficient bone for me to place conventional implants, so, and a few teeth need to be removed. So we went ahead with the lower arch first. Okay, so we extracted those teeth. When in treatment, when I do this full arch cases, always one thing that I do is to have a diagnostic wax up of the patient. That's the first thing in my treatment planning, because before I commit anything to the patient. So the moment patient comes to my clinic, and I explain him how the treatment goes, and if he agrees to the treatment, then before committing anything to the patient, then I need to have patient's x-rays, patient's models, then jaw relation records. The models have to be mounted, and we do a diagnostic wax up. That means a trial denture is prepared for that patient. On that trial denture, I make a night guard. That night guard serves to some extent as a stent for me, helps me position my implant in a better way. So in this case, what is your treatment plan? A removable prosthesis, a fixed prosthesis, a hybrid prosthesis? You graft the, you can see there is hardly 1 millimeter bone below the maxillary sinus on each side. Anteriorly also there is hardly any bone. Okay. Patient is having a submucous fibrosis, late 60s. Okay, there is not too much of a restorative space, and as I told you, he is a beetle nurture, so his masseter also is hyperactive. It's very, very well developed. So you need to identify the forces which are going to impact your ultimate outcome of the treatment. Okay, so what we did in this case was, as I told you, a diagnostic wax up and a surgical stent. So I start my pilot drilling through the surgical stent, and then we place implants. My favorite configuration, 6 implants in the mandibular arch. In this case, what we did different was, we used titanium wire. Okay, to join all these abutments together. The process is known as Syn Crystallization. Now, why do we do Syn Crystallization, and in which cases do we do Syn Crystallization? I mean, we don't have sufficient time to talk about it in detail, but you can refer to the 2006 article by Degidi. He has explained Syn Crystallization very nicely. So basically what we do is we splint all these implants rigidly with a metal wire. And why do we do that is, as I told you, patient's masseter was hyperactive. Patient all his life was used to chewing with very high forces. And in full arch cases, when we give provisional restoration, especially immediate provisional restoration, and we are supposed to wait for 3 4 months for till the implants integrate, what we find most of the times is this temporary restorations do fracture, and they do fracture somewhere between canine and premolar region, probably because there is a curvature of the arch and more lateral forces and so on. And mind you, my dear friends, if your provisional restoration fractures during the healing phase of the implants, and if the patient doesn't come to you immediately, your implants are bound to fail, and we don't want that to happen. So to be honest, safer side, what I did in this case was, I placed 6 implants. I placed 6 implants, and then we joined all those abutments with the titanium wire and gave him a provisional restoration. We also have saved those 2 canines. As of now, we'll talk about it later, what we did with those canines. But as of now, as an additional support, I have saved those canines, okay, and gave him provisional restorations. And trust me, this patient over the next 3 to 4 months came at least 5 6 times with a fractured provisional restoration, and luckily I was saved, even though the restoration used to get fractured so many times was just because of intraoral welding. Okay, I joined all these implants rigidly with titanium wire, and that is what saved me from a big embarrassment. So once these implants integrated after about 3 months, we went ahead with our final impression. This is the splinting of impression, post the impression, the jig trial, the jaw relation, and the metal trial. Now when I got this metal trial, what I instructed was, you remember, here also you can see during the jaw relation phase, both the canines are present. And where are these canines gone now? These canines are submerged. These canines were supposed to be root canal treated because there was root caries, but still the support was good. They were not mobile. So what I did was, I did endodontic treatment for these canines, and they initially they were used in provisional restoration. Later on, at the time of this metal trial, you can see there is a perio probe placed between the canine, and there is a space. The This space is to tell the technician how much ceramic needs to be added over there. At the time of metal trial, what I did was, I cut this canine to the bone level and submerged it. So it's such photograph you can send to the technician. He will add ceramic on the tissue surface of the framework, leaving about 2 millimeters of space for the soft tissue to grow between the root piece and your prosthesis. And this is the metal trial and the ceramic that is fired on it. And this is how we give the final restoration. You can see that there is no space in the canine. This is a full arch screw retained PFM bridge, one piece on 6 implants, and the patient is using it for about close to 5 years now. What we did for the upper arch, I have not mentioned anything about upper arch because I did not treat the upper arch. For my best friends, very very close friends, Dr. Vivek Gaur, who is the master of basal implants, I called him to treat the upper arch, and he obliged. And this is where we started from, and this is where we ended. Upper arch was treated with basal implants, 10 of them. And trust me, he is like a boss of basal implantology, and even he was sweating while placing these implants. So it was really really tough to place these implants in submucous fibrosis case. And lower arch, you can see both these canines submerged at the level of the bone, and nice prosthesis. It's been close to 5 years. The patient is absolutely happy with it. So friends, what I wanted to tell you over here is the practical way of treating some of these cases. 30 minutes is hardly any time to talk about this topic, but at least I think I want to do a justice by giving you just an idea. This is just an eye opener about how we can treat this case, such cases practically. Always remember one thing, that a treatment plan always has to be prosthetically driven. Okay, so that is the key in treatment planning. So, what are the points that we need to remember when you're planning any full mouth rehab cases? Number one is the incisal edge position. That is fairly fixed. And then, according to your incisal edge position, you need to decide the type of prosthesis. Your incisal edge position is fixed. You know where the bone is, and the space in between the two have to be filled with your prosthesis. So, you need to know when to give a FP1, FP2, FP3 type of prosthesis. Second is the restorative space. Now, this restorative space is one of the key factors in deciding the type of prosthesis. You can have minimum space, you can have about 10 12 millimeters, you can have 15 16 millimeters of space. So depending upon the restorative space, your treatment options do change. Okay, third is the lip line. Now that is something which is very very important. Okay, fourth is the contours and emergence, the tissue contacts. You need to develop these tissue contacts with your provisional restorations. And why do we need to develop them with your provisional restorations? Is because they will reduce the food trapment, they will make our contours cleansable, and they will eliminate the speech impairments. This is how you need to give your uh, uh, the contour to the tissue surface of your provisional restoration. The tissue surface has to be absolutely convex so that it does not become a foot trap, at least during the healing phase. Then one of the most important things that we need to consider is the forces acting on the implants. In one of the cases, when I was talking about the last case, uh, I talked about the forces that were acting on the implant. So we need to calculate those forces, because ultimately it's the perpetual preservation of what remains than meticulous restoration of what is missing. That's the demand's dictum. Okay. So, one of the last thing is the selection of the type of prosthesis. As I told you, that depends upon so many factors: the restorative space, the lip length, the amount of bone available, and accordingly, you will decide how many implants to place, where to place, whether the patient needs a lip support or not. Okay, and that will determine whether to give a fixed prosthesis or a removable prosthesis. Lastly, I want to mention these four golden rules which you have to follow in each and every case when you plan a case. Number one is no cantilevers. The second rule is no three adjacent pontics. So you place your implants so far or so close to each other that there should not be three adjacent pontics. So you know where you place your implants. No cantilevers. Do not give any kind of cantilevers. Cantilevers are very, very detrimental for implants. The canine molar rule: whenever maxillary canine is missing, whenever maxillary first molar is missing, you always have to place implant in that region. Okay, there is no option. And arch dynamics: Edmund Bedrosian has classified the maxillary edentulous arch into five segments. The four central incisors form one segment. Each canine is an individual segment, and two premolars and first molar form one segment. And he advocates at least one implant in each segment. So to start with, we have five implants in maxillary arch, and any factor that goes against the force factors, the density of the bone, the volume of the bone, the direction of the forces, whatever goes against the biomechanics, you go on adding the implants. So as I said, most of the time my treatment planning is 7 to 8 implants for maxilla. Okay, so these are the golden rules. Follow them, and I'm sure you will definitely not go wrong with your treatment planning, and your final prosthesis will stay there for ages. So I think I'm well in time, Dr. Rajiv. Thank you very much, ICPA. Thank you very much, Dr. Rajiv Chidgupi, for inviting me. 35 minutes I mean,
Absolutely.
hardly any time to talk about, but I just have introduced you to the full mouth implant rehabs. We do conduct courses at Thorat Implant Institute. For details, you can contact me, or you can contact me through ICP or directly as well. I am available on Facebook as well. And or you can type Thorat Implants Institute, and you are most welcome to join our upcoming full mouth implant rehabilitation course. Thank you very much, Dr. Rajiv.
Thank you, Amol. Thank you so much. You finished
It
the
was my
lecture
pleasure.
exactly in 35 minutes. You have always managed limited spaces. Now you have managed limited time also very well. So you've oriented all of us very well in time and space. A lot of high yield facts that you have given, a lot of clinical tips, especially for beginners. I hope everybody has absorbed all those things. A few things I want to, what you can say, I want to repeat those things, and I'll try to see if you can put the same things in different words. I want them to reach the audience in twice or thrice. So just a general my own curiosity question. I've been with you. I've come with you for so many your consulting cases, and how many removable cases and how many fixed cases in your full mouth rehabilitation, implant rehabilitation nowadays? What is the ratio, rough ratio?
Removable would be, I see, normally I do about 50 to 60 full mouth implant rehab cases per year, and maybe one removable case in 2 or 3 years. That's it. Maybe
Oh, so it's,
1%.
so it is mainly fixed.
Yes, almost always fixed. Less than
Okay.
1%.
And I saw in one of your cases root submergence. I think everybody should make use of root submergence. It's a very vital component, biological component that will preserve the osseous architecture. I'm very happy that you showed that case and you emphasized on that.
Yeah.
And
So the advantage of root submergence is you preserve, as you said, the architecture of the bone, the proprioception, and we all know that the once the tooth is lost, the bone is lost, the alveolar bone is lost, and what happens below the pontex is over a period of time, the bone resorbs, and there is a space created beneath the pontic which acts as a foot trap, and then patient comes every maybe a year or 2 years saying or zyada space बढ़ गया, and then you don't know what to do. And I mean that's a problem which keeps lingering over a period of time. So now in last like 6 or 7 years, I have, wherever I'm not placing implants, I'm not removing those roots unless they are badly infected. If they are
Okay.
like or periodontally absolutely periodontally compromised, if they are badly infected, I still, and they are stable, I do endodontic treatment and submerge them. If they are absolutely vital, there is not even any need to do endodontic treatment. You just cut them, submerge them at the bone level, and cover them with a connective tissue or a free gingival graft, and the vitality of the root is maintained. I think as
Okay.
a periodontist, you must be advocating such things.
So, another question specifically for beginners: what characteristics to keep in mind in selecting an implant system that a beginner feels is very user friendly for him and in his initial cases of FMIR? A lot of questions have come in the same regard: what I should look for in a system, which systems I should go for. So, in general, if you want to tell them 3 or 4 points, these are the 4 points that should be there in a system. If you have them
How
in
do
your
we
system,
choose an implant system? Yeah, the basically the gist is, how do we choose an implant system for a full mouth implant rehabilitation case?
yes.
So my answer would be, choose a system which has got prosthetic components available. Okay. Yeah, implant, I mean you can place any implant, that actually doesn't matter. Okay, but I know some systems who don't have castable abutments. I know systems who don't have multi-unit abutments, and you are fixed with one type of prosthesis. That becomes very very difficult. In fact, procuring the components at a later date also becomes so much difficult. So choose a system. I'm not saying go for a very cheap or go for a very high end system. Choose a system which will have the prosthetic versatility, which will give you an option of giving whatever prosthesis is required for that patient. I mean, don't never go with something in mind, I want to do this in this patient. No, evaluate the patient's clinical situation, and accordingly you need to, as I told you, it's a prosthetically driven treatment plan. So you see what is required and what can be given in this case, and accordingly you can choose a system. Any good system will have a good prosthetic versatility. I don't want to name any system in particular, but yeah, whenever you are choosing any system, see to it that you have prosthetic options, all the prosthetic options in that given system.
Okay. Okay, this is one thing that something I'm curious myself. What made you switch from 2 to 3 sections of prosthetic sections to single piece prosthesis? What was that case? What made you switch? Try it out in that first case, and what was your learning? What was your experience from the first case?
See, the problem with split frame prosthesis is aesthetics. I mean, if you are making it in two parts, you have to split it somewhere in the anterior region. Okay, so then for the technician to match those two parts becomes difficult, and you can clearly make out that there are two different pieces. Number one. Number two, they say split frame prosthesis because retrievability becomes easy. Now, again, tell me practically, those who are doing implants for more number of years, 10 years, 15 years, or even my seniors who are doing, I'm doing for 17 years, whoever it is doing more than that, how many times do you actually remove the prosthesis for a follow-up? Unless the patient comes with some problem, we are not going to remove it. If the prosthesis is absolutely well fitting, there is no foot lodgement down, patient is maintaining it nicely, why do you need to remove a prosthesis to just check that everything is good and then again screw it? Mind you, every time you remove a prosthesis and torque that prosthetic screw, which is just 1.2 millimeters in thick, every third time you have to change those screws. Who pays for those additional costs? We are talking about a price sensitive Indian market. Patient has paid you in lakhs, and then every 2 years you are asking the patient to pay 10,000, 20,000 rupees for a follow-up. Patient will stop coming to you for a follow-up. That was one reason. Number two, they say that mandibular flexure affects or may affect the implant bone interface, but the fact is that happens posterior to the molars, posterior to second molars, second premolars. So when I place these implants, and we always advocate a shortened dental arch, that means we are replacing only first molar to first molar. So if I place my implant distal to the second premolar or in the mesial half of first molar, then I'm not cantilevering anything, maybe just a half a tooth. And then again, there is no question of mandibular flexure in premolar and first molar region. If I'm placing my implant in second molar region, then yes, probably mandibular flexure would come into play. But I am replacing only 12 teeth in one arch, and I'm placing my distal most implant in the mesial part of first molar. So practically, I don't think mandibular flexure does play that much of a role. And that's how I started doing this. And past like 11, 12 years, all my cases, they are like one piece prosthesis.
Okay.
I
Okay.
didn't
Great.
find it necessary to remove the prosthesis just for a checkup. That doesn't make sense to me.
Okay. And another thing I learned from these lectures, do you recommend intraoral welding to the beginners? Will it make a big difference to their initial years, initial cases?
Whether it's initial or advanced, intraoral welding is one of the very, very important tools. As I told you, if you are loading the implants immediately, then nowadays, last 4 years or so, 4 5 years, almost all my cases of immediate loading, I do intraoral welding because I don't want to take a risk, because there are very high chances that in canine premolar region that a provisional restoration breaks, and then I don't want to take that risk of implant. I have been through it. The implant is lost. I have to redo the case, and it's a big pain. So it's better we invest in these intraoral welders, and it's a one-time investment, and recurring cost is hardly anything. 200-300 rupees for a wire, and that's it.
Okay. So there is one question here from the audience. How do you make sure that you have accurately registered centric occlusion and centric relation in FMIR cases? I don't know. It's a very big thing. It's
Uh,
best if you can give a short answer.
yes. The tentative, see, before the case we have already taken patients jaw relations. So if we have natural teeth, even if I have to remove them, I do, I mean, in one of the cases the posterior molars were there, I mean the distal most teeth, if you remember, they were kept. These teeth act as vertical stops. So when, even if one natural tooth is present in the patient's mouth, retain it at least till you take this jaw relation records, because then the patient will have a proprioception. At the same time, you will have a vertical stop. So when you have a vertical stop, there is no question of vertical relation. And because the patient has got those teeth, one or more teeth, the proprioception is present, it is very easy for us to guide the patient into the centric relation. So that is not a major hassle, practically speaking. Yeah,
Okay.
and then when I take this jaw relation, I take two times. One is at the time of jig trial, we take one jaw relation, and when we get the framework trial, again we take another jaw relation just to verify that the first one was right.
Okay. Okay. And there is a question, I think you are the best person to answer this. For a rural practitioner, can full mouth implant rehabilitation be started considering the accessibility to CBCT? Would they still obtain predictable outcome of the
100%.
treatment if they don't make use
100%.
of CBCT?
See, I have been doing full mouth implant rehabilitation before the CBCT era. So I started my implant practice 2005, and first CBCT in Pune was installed, I think, in 2011. So all those 6 years, I was doing my full mouth implants without CBCT. After that, also nowadays, because we have readily accessibility, we are getting the CBCTs done. But if you have a OPG and if you can read the clinical situation well, then I think we can go ahead with a routine OPG as well. I have done my first. I'm not boasting. I've done my first zygomatic implant in 2012 without a CBCT on a OPG. So there is something known as a bone caliper. So you can use a bone caliper to measure the buccolingual dimension of a bone. And if you have a OPG, then 20 to 25% of elongation you can, magnification you can adjust on a OPG. And then plus we have IOPS intraoperative. So also that can be done. If you want to find out a way, you can find out,
Okay.
definitely.
There is a question. Please comment on basal implantology in FMR. One advantage or disadvantage over conventional. I think he has already shown a case where he made use
I've
of
shown a
basal.
case.
Yeah.
Yes. It's not that whether I'm a fan or I'm not a fan, or whether I do or whether I don't do. I do basal implants, but that forms only about 5% of my implant practice. 95% of the time I do conventional, because probably I have started conventional before and I have been doing conventional for so many years. I'm more confident in it. That doesn't mean that basal implants should be out of your practice. They have their own indications, and whenever indicated, you have to go ahead with basal implants. I mean, for the last case, when I showed you the last case, patient is like 65, 67-year old, SM or submucous fibrosis. At this age, do you want to release those bands and open his mouth and do all these surgical procedures to place zygomatic implants? Come on, do you want to do this in your father? My answer would be no. So what is the option? Basal implants, flapless, and it serves the purpose. So, and it is staying for quite some time. My first case was done in 2015, and it's been 6 years since I am following up that case, and it's working. So absolutely no problem in using basal implants in indicated cases. I have seen patients doing it right and left. Again, I am against it. Yeah.
Okay. There is a question on jig trial. What is the best tip you can give for jig trial? And also there is a question, what will you do if the jig fails in the mouth? Jig trial fails in the mouth. Fails or falls
There
in the
is
mouth, I
no
don't know.
there is no trick for jig trial. Your impression has to be accurate. Okay. And if the jig trial fails in the mouth, that means it is not sitting passively. Then you have to cut it, and you have to place those posts again and join them as the way you do it for final impression, and repeat your impression. There is no shortcut to it. You have to repeat your final impression.
Okay. Can you repeat canine molar relationship? I don't
The
know. I
rule you
think
mean to say? Yeah, it's the rule
that is
number
the only line.
3.
Can you please repeat canine molar relationship? I think you described something in
Those
one of your
rules.
earlier
Yes,
cases and
yes,
it
yes,
it
yes,
is
yes.
not yet clear.
It's
Uh,
it's one of those rules, rule number 3, which says that whenever a maxillary canine is missing, whenever a maxillary first molar is missing, you always have to place implant in that region. So when I'm treating edentulous maxilla, always I will place one implant in canine, always I will place one implant in molar, and always I will place one implant in anterior region for the four incisors, following the Bedrosian's rule. And then we calculate the forces, and if say bone density is less, I add one more implant. If angulation of my implants is not proper, I add one more implant. If the bone is very less, I have to do augmentation procedures, or if I am compromising on my implant size, then I add one more implant. So that amounts to 7 to 8 implants, but this works as a starting point. So many people ask me how many implants are required for a full arch. So if you follow these rules, no cantilever, no three adjacent pontics, and canine and molar implants, then I think treatment planning becomes child's play.
Great, great. There is another question. In your experience, what changes have you observed with respect to TMJ in long-term follow-up full mouth implant rehabilitation cases?
If your jaw relation is good, if your occlusion is good, one of the questions was what kind of occlusion you give. If you are giving a fixed prosthesis, your occlusion has to be a group function mutually protected occlusion. And if you are following these protocols properly, then there is no reason why there should be any adverse changes in the temporomandibular joints. No, I have not seen that. That doesn't happen, at least in my cases, unless you have grossly gone wrong. There are premature contacts, but then the first thing that will go in such cases is the ceramic, or the prosthetic screw will start loosening, and you'll have problems with your prosthesis than having it in the TMJ.
Okay. I think we have pretty much covered almost all the questions. It has been a great session. You have given a lot in short and sweet format. There was a lot for the beginners to take home, and I think it will give them a lot of motivation as well as confidence to start with their full mouth implant rehabilitation cases. And also those people who are already doing full mouth rehabilitation cases, if at all they had any roadblock in between, they have got a lot of clarity from your lecture. So thank you so much for this wonderful session, Dr. Amol Thorat, and we wish you all the best in your newer experiments that you keep doing, and for all the wonderful results that you have been consistently getting. So I wish you more power and
Thank
more
you
success
so
in
much.
all your ventures.
It was
And
my privilege to be invited to deliver this lecture. Thank you, and I thank ICPA team also for inviting me for this.
our privilege, our privilege. So thank you, everyone. Thank you, audience, for being here. Thank you for all the great questions that you have asked, and hope we have answered all your questions. And I hope there was a lot to take home for each one of you. So that brings us to the end of eighth episode of ICPA Clinical Series. The theme of ICPA Clinical Series is each episode one clinical challenge. Soon we'll be coming up with the ninth episode with another clinical challenge. We'll try to again keep it as clinically relevant as possible. So thank you, Dr. Amol, once again. Good night. Good night, everybody,
Right. Good
and
night,
enjoy
all.
the winter season. Thank you.
Thank you.